Good afternoon and welcome. I am Norbert Claude Gorin from the Department of Hematology at Hopital Saint-Antoine and also the chair of the EBMT Global Committee. This is our webinar number 5 dedicated to viral infections, and you will not be surprised that we still have to speak about the COVID. This webinar, as the previous ones, is supported by an unrestricted educational grant from Air in Space, and I feel grateful to Air in Space for this. I would like also to draw your attention to the fact that after the speakers have presented their lectures, please do not forget that we meet around 3 o'clock Paris time to have a live discussion of about 30 minutes. You can send your questions during the presentations whenever you wish. These are my disclosures for these presentations. And I have a few slides I would like to show you to introduce our talk. First of all, between the 6 months separating our previous webinar in November 2021 and this present webinar, you have here the number, the global case count in millions of people infected by SARS-CoV. And as you can see, we went from 255 million people to over 500. So it doubled, meaning that it's not yet finished. The number of deaths also went from a little bit more than 5 million to more than 6 million. It's huge, it's a disaster. But on the other hand, if we want to find something optimistic, we will say that the death rate has gone down from 2% to 1.2%. And the total number of vaccine doses administered in billions has gone from 7 billions to more than 11 and almost 12 billions. On this slide, which is published usually by the Johns Hopkins site, you will find on the left hand the number of people vaccinated, meaning 2 vaccinations in, let's say, developed countries. And you will find, of course, that the fraction of vaccinated people is indeed very high. But the problem is on the right-hand side, because the more red it is, the more it shows you where unvaccinated people are and the number of unvaccinated people. And to make it short, I would say that only 16% of people are vaccinated in low-income countries. So it would be totally wrong to think that everybody on this globe is vaccinated. On the other hand, in well-developed countries, it is still true to say that vaccination prevents from hospitalization and most of all, hospitalization in ICU and death. Is there a treatment for COVID at this moment? Unfortunately, I would say no. This is a meta-analysis that was published a few months ago with 3 drugs, molnupiravir at the top, fluvoxamine, and then I put a red arrow for Paxlovid, which is said to be the best and which is reported as decreasing by 85% the risk of COVID. But Paxlovid has to be administered in the first 3 or 5 days of occurrence of the symptoms, and it has to be administered for only 5 days. And therefore, the question is, to which patients are you going to give Paxlovid? Taking into account, in addition, that we unfortunately have some bothersome side effects, and also that we have drug interactions. So I can tell you that, for instance, in hematology, deciding to give Paxlovid to a patient under chemotherapy with myeloma or a patient during the course of a transplant is not an easy question to solve. To end my presentation, I would like to remember you, and everybody knows that SARS-CoV is not the only virus that bothers us. And I took this slide from Per Jungmann, who presented, I think, at webinar 3 or webinar 4, a review on all infectious diseases. And you have here the list of all the other viruses, not even mentioning the new monkeypox problem. As you know, the monkeypox, which we can see on the left side here on electronic microscopy, is not a major problem in developed countries because the older part of the population, but only the older part, has been vaccinated against smallpox, meaning against the vaccine virus. But still, this is a new occurrence of viral infection. So prevention is really the key for viral infections. And I'm always presenting these already old slides I took in China of plasmid to filter fungi, viruses, bacteria, or even more special rooms called biocare. And you see only the door, which are able to change the pressure inside with just a switch from positive to negative pressure. So now we are starting our webinar, and we have three renowned international experts. The first one will be Professor Bruno Lina from Lyon, and he will tell us where we are exactly for COVID and what, unfortunately, we have to expect. The second one is Emmanuel Bernoulli from Dassault Systèmes, and he is very interesting because he will present the 3D modelization of bio-aerosols dispersion. And the last one from our university, Paris-Sorbonne, is Professor Vincent Maréchal, who is very famous in France for developing the OBEPINE network, which checks in wastewaters the presence of the viral RNA and can predict what is going to happen in the following days. So again, Q&A at the end. And having said this, I would like now to ask Professor Bruno Lina to give his lecture. We will meet again around 3 p.m. Thank you.
So good afternoon to everybody. I'm going to present you some of the speculation we may have regarding the evolution of the SARS-CoV-2 pandemic. And actually, I will try to explain to you what the past can tell us to try to speculate to what will happen in the future, knowing that there's a lot of uncertainty and unknown, but still we can start to think of what will be our future with this virus. So I have no conflict of interest on that topic. So the virus, when it came out, actually out of the reservoir, was a virus that was perfectly fit to replicate in human respiratory tract. And that's the reason why this virus spread so rapidly all over the world. We accumulated a lot of knowledge on that virus. And as you can see here, this is a round-shaped virus, which has some very important protein at the surface of the virus called the spike protein. And this spike protein is present on a limited number of protein at the surface, only about 30 per virus. But this protein is very efficient to bind to receptor binding domain through the end of this of the protein. And this protein is also able to really tilt at the surface of the virus so that it could bind to the receptor very efficiently, even though the receptor is not straight in front of the virus. So, and the receptor that is used for binding is the ACE2 receptor. So if we come back from the very early times of the pandemic, it is pre-pandemic time actually, what we have seen is that there's been introduction of viruses from the animal reservoir. And when we have been looking back at the lineages of the virus that have been introduced into humans, there has been two introductions of two different viruses at the same place around Wuhan. And actually only one of these, lineage A, took over the other one disappeared. And from that stage, we identified two things. First of all, there was a risk of introduction of a coronavirus. And this coronavirus was actually spreading from humans to humans, but it came from an animal reservoir. And as you may remember, we have been looking at the origin of this virus. And at some stage, the pangolin was supposed to be one of the intermediate hosts, but this has not been confirmed. However, what has been confirmed is that when you look at the different bat coronavirus that you can detect all over the southeast of Asia, you can see that there's a lot of viruses that are very close to the SARS-CoV-2 that are circulating in these animals, in the bats. So the reservoir is huge. When this transmission occurred, actually, the first stage is very difficult to know. However, what we do know now is that from this reservoir, there might have been, very likely, an intermediate host where whether this intermediate host was in the wilderness or in the markets, we don't know. But what we know is that the onset of the epidemic really started from the Huanan market. And that is the place where, this is the map of the market here, and the red, the more red you have here, the more frequently the virus was detected at the surface of some spaces in the market. And it shows that the virus was really starting from this place to disseminate from maybe animals, we didn't find which animals, but maybe from animals to human. The lineage took over, despite there was two lineages, and human cases were recorded in this same market. And then afterwards, the epidemic started in a community of Wuhan, close to the Huanan market, and then it disseminated in the whole city and all over the world. And when we look at the viruses that were detected at a very early stages, this is a phylogenetic tree of the virus. The original tree, the original virus is here. And what you can see is that all the viruses that have been detected at the early stages up until February 2020 were very, very close, and they were all descending from one single virus that was the original strain. All these viruses had the same feature, as I tell you. This is the spike protein, which is important for the binding. This is the ACO2 domain, and we know that this interaction between the receptor and the virus was excellent, allowing the transmission of the virus from human to human. But what we also know is that these viruses undergo a lot of different steps of evolution. And the very first step was seen actually in February in Europe, when there was, this is the spike protein, this is the receptor binding domain, and this is the ACE2. And what happens actually in the middle of the spike protein, the trimeric protein, there was one substitution that was incorporated, the D614G mutation. And this mutation allowed a kind of change in the protein, in the trimeric protein, allowing two things. You have to see this protein, the spike protein, the trimeric spike, as a blossom. And actually, by introducing this mutation, the blossom tends to open a little bit itself. And by opening the blossom, actually, it allows the specific domain, which is called the receptor binding domain of the protein, to be in a conformation that facilitates the binding to the receptor. And this receptor binding domain here, with the help of this mutation, tend to be more frequently in what we call an up position. And this up position allows the binding to the ACU2. And when you have this protein that incorporated this mutation, then the binding to the receptor was enhanced. And then it allowed the virus to disseminate very rapidly. And that's really the first process of evolution of the virus, where this genogroup, the G genogroup, which was having the signature of this mutation, D614G mutation, became the predominant virus very early in May. And it was actually the root of all the different lineages that emerges after that. The other viruses disappeared. And this evolutionary process actually started with this mutation, but there were a couple of steps that we have seen after that. And the second step of evolution we did see was the emergence of the first round of variants. And this first round of variants were the alpha, beta, and gamma variant. And something which is interesting is that the alpha emerged in Europe, the beta emerged in South America, and the gamma emerged in South Africa. 3 different locations. But when you look at the timing of emergence of this virus, that was pretty close, almost at the same time. And the peak that you could see, and this is the data that we have from our world in data, when you look at the peak of these viruses in the early stages, it appeared approximately at the same time, as if there was a time for evolution at that virus when the new variants emerged by the beginning of autumn 2020. And after that, we have the Delta wave that came a little bit later. But let's go back to all this emergence of the virus. Actually, these variants acquired specific mutation, and I'll come back to that. Each of these mutations were responsible for an enhanced transmissibility, as shown here in this graph. You have an R0 on R ratio here. This is the R0 on R of the original strain. The original strain had an R0. When you divide it by its own R0, it gives 1. But when you took when you use this R0 of the original strain as a numerator, what you could see is that when you look at the R0 of the new viruses, the variants that emerged, you could see that there was a real increase in transmissibility. And this increase of transmissibility was about 2.6 times higher with the Delta strains. So these viruses were highly transmissible. So what were the mechanisms of that? When you look at the evolution of the bulk of the virus that were detected worldwide, each time you have a variant that was having an increased transmissibility, it had a tendency to displace all the other variants. And this was really clear with the Delta, not as clear with the Alpha, Beta, and Gamma, but really clear with the Delta. So what was the processing for displacing the other viruses? What you have here on this panel is the receptor binding domain of the original virus. And in green, you have the interaction domains with the actual ACE2 protein. And you can see that these domains of interaction between the RBD and the ACE2 is really large. And when you look at the two first variants, alpha and beta, you could see that some of these mutations actually that were early stages occurred in the zone that were interacting with the receptor binding domain and the ACE2. And when you look at one mutation, actually, that was common for all these viruses, it was also detected in the gamma, that's the 501 mutation. And all these viruses evolved at the same time with the same mutation, knowing that beta and gamma was having in addition 484. And when you look at these mutations and you look at the fold of change of binding according to this substitution, what you can see is that the introduction of the N501Y mutation increased binding by about 30%, which is very important. And this increase was even higher with the beta. However, there was something that was called also an evolution with an epistasis, is that when you look at only this substitution, 417, when it's alone, it reduces the binding. However, when it's in the context of these two other substitutions in addition, then it doesn't reduce the binding, and it even enhances even more the binding. So this kind of evolution, when you have an additional different substitution that may have an increase in binding, you can see that even sometimes some mutations that are supposed to be deleterious are beneficial for the virus. And when you look at what happened with the Delta, actually Delta introduced two other substitutions. It was a virus with an enhanced transmissibility. And when you look at the position of these two key substitutions observed in the Delta virus, actually, they're in zone where there was no interaction with the ACE2. And by introducing these two substitutions, it has actually expanded the binding domain. So that's the reason why these viruses were more transmissible. They bind much better to the receptor. That's the first thing. The second thing is that associated to this evolution, there was also consequences in terms of escape to the previous immunity. And we call that kind of antigenic evolution that you can analyze through two different features, which is the antigenic mapping, looking at what was the distances between the viruses, and I'll come back to that, and the antibody landscape, sorry for the mistake, the antibody landscape of those that have been previously infected, and to see whether these antibodies can protect against a new coming virus. So overall, how does work antigenic cartography? This is something that has been developed by Derek Smith. a very comprehensive way of understanding what are the level of escape to previous immunity of the new viruses. It's based on serological data, and you have individuals that have been immunized as when they were naive with one antigen, actually that was the original strain here, or that could be one of the variant strain here. And you test the sera of these individuals against all the different variants. And by doing so, you can more or less measure the reduction in protection that you have on average when you go from one virus to the other. This reduction actually is directly correlated with the difference in terms of distance that you have between the different viruses that are on these two-dimensional map. You can see that as a roadmap, actually, where you could locate the different cities according to the antigen, the kilometric differences between the cities. And by doing so, we know that, for example, when you look at the original strains, we could see that the alpha virus was very similar to the antigenically to the original strain, because actually there was no difference. And we know that the 501 mutation didn't infer any antigenic difference. Whereas when you look at the beta or the gamma viruses, the fact that there was additional mutation, the 417 and the 414, tend to have a less good neutralization, although it remained pretty good. And so that the virus were moving away from the original strain in terms of antigenicity. And you have here located the Kappa strain and the Delta strain as well. As you could see, during the early stages of evolution of the virus, actually, there was a kind of radial diffusion of the viruses from the original spot. And the second thing I wanted to explain is that we have to look at the antibodies landscape. If a virus is far from the original virus, but if the antibodies remain still efficient because they are very high titers to protect against infection or protect against severe disease, then it means that the protection you have with the original strain remain at a level high enough to prevent a severe infection or an infection. And actually, the very early data that we had with the emergence of the Kappa strain or the beta or the gamma viruses showed that when you had a good immunization, well, actually, the antibody that you had were protecting against all these viruses. So there was no significant differences antigenically between all these viruses. And that was the reason why we kept using that virus as a vaccine. Whereas if there was a decline that would have been too important in terms of antibody landscape for one of the variant virus, then it would have driven us to a change in the vaccine composition. Well, that was not the case. And then after these first waves with the different viruses, we had the Omicron wave that started. And that was huge in terms of number of cases. What happened actually is that this virus, as you could see here in the spike, accumulated a number of substitution and mutation that was very, very high, including in the receptor binding domain. And this led to the emergence, as you could see in that phylogenetic tree, of a new deriving from a G clade, a new virus that was Omicron. But this Omicron virus was starting from the root of the G viruses. It was not something that was deriving from Delta, Beta, or Gamma. It was deriving from the root of the viruses, not more. The displacement was very fast because this virus was highly transmissible. And we could see that worldwide, Omicron became predominant in a couple of months. Again, when you look at the original binding domain between the RBD and the ACE2, and you look at what happened with the changes that was accumulated in the RBD of the Omicron virus, you could see that there was an expansion and there was some changes in the virus that really induced a very high binding. And when you look at the wild type binding here and the fold change in terms of binding to the receptor, you can see that the Omicron virus is really binding about something like 50 times more than the original virus. So this virus was with a very high affinity. The second thing is that within the mutation that was acquired by the virus, there were mutations that were close to the receptor binding domain, as you can see here, and there were other substitutions that was seen on the flank of the RBD, of the protein. And actually, these mutations were responsible for a change in the structure of the protein, and this change resulted in the fact that the receptor binding domain that had the tendency of being up since the emergence of the D614G mutation, well, this up position of the RBD was even more enhanced by these three substitutions that were observed here. And basically, with Omicron viruses, all the RBD domains are almost every time at the up position, which again facilitates the transmission of the virus. So you have this binding capacity that is enhanced, the up position of the RBD, and in addition, when you look at the antigenic map, this was the first round of viruses. When you look at the antigenic map, this virus seems to be much further distant as compared to the original strain, which means that the protection you have in terms of immunity when you're vaccinated is reduced as compared to what you could see with the previously circulating viruses. And actually, again, what we checked in terms of antibody landscape is that, and this was preliminary data that again was provided by Derek Smith, and you could see that on the blog he's having. So when you look at the level of antibody, very early after vaccination, you could see that there was huge difference between 2 and 3 vaccinations. However, when you look at distance there, it seems that the reduction in terms of protection is really dropping down, and it means that with 2 doses, more than 6 months after vaccination, you're not protected anymore, even though you're still protected with 3 doses 1 month after infection. So there was a question at that time whether this evolution was showing the trend of evolution of the virus towards what Omicron would become afterwards, and if the descending viruses after Omicron would be Omicron descendants. And the first identification of a virus that was not rooting from the G viruses, but rooting from Omicron was the BA2 variant. And as suggested by Etienne Simon-Laurier and Olivier Schwartz, they said that maybe it was the beginning of the evolution starting from the Omicron root and not anymore from the G root, which was the original viruses. And again, when you look at the evolution at distance, so the BA2 become predominant, it displaced the BA1, and these viruses really came out of the BA1 viruses. So when we look at the different antigenic distance between BA1 and BA2, although these viruses were having different roots, the distance in terms of antigenicity as compared to the original strain was not enhanced. So the question was about, what about BA4 and BA5? And actually, I will show you later that BA4 and BA5 are not that far from the original strain, and it is a new cycle that is just that has been implemented from the virus. But again, when you look at the antibody landscape at BA1 and BA2, it really shows, and the GMT landscape is very talkative. It shows that when you are away from a vaccination, what happens is that you have a drop in protection, and you might be infected again with that virus. And this is somehow restored when you have multiple injections of the vaccine. And the second thing is that when you look at infected individuals and infected and vaccinated individuals, and this is what is showing this paper, when you have been infected with BA1, you have antibodies against BA4 that are protective, and BA5 also. And this is better when you are vaccinated in addition to the infection than just infected. So the combination of the immunity you got with vaccination plus infection is really increasing. And the situation as it is described again by Derek Smith is that when you look at the position of the different BA viruses, they are really not moving progressively distance from the original viruses, but they are evolving on a kind of circle around the virus. So there's no big differences in terms of antigenicity, in terms of cross protection that you may have between the wild type and the other BA viruses. And again, this also is explained by the fact that you have here all the BA1, here you have the BA2, and actually BA3, 4, and 5 are linked to the root of the BA2. So it's not further evolution as compared to BA2, it's close to BA2. But still, what we do see in Europe is that there was an upsurge of cases in Portugal because of BA5 that is circulating, and we tend to see some increasing number of cases in the other European country with BA5, although the numbers we have are much smaller than what we see in Portugal. The big difference between these countries and Portugal is that there has been no BA2 epidemic in Portugal during between the BA1 and the BA5 circulation. And again, when you look at the antibody landscape, what we see, to make a long story short, based on the antigenic map and the landscape we have with GMT antibody, when you are vaccinated and infected with BA1, it seems that this antibody landscape allows you to be protected, at least on the short term, against all the different viruses and all the different Omicron variants that you could see circulating actually. So what about the future now? So there's a couple of questions going on. What about seasonality? What has been seen in the Southern Hemisphere, and especially in South Africa, in that there was an almost 6-month seasonality between the peaks. So it's interesting because it never went down completely, but there was an increase and then a reduction. And this is the last BA5 increase. And you can't compare these different peaks because the number of testing was not the same. But you can see that there's a seasonality every 6 months. So are we going to have a 6-month seasonality before the yearly seasonality? Well, I don't know. We shall see. And you know, there's also possible evolutionary pathways. And amongst the evolutionary pathways, we have to think about the recombinant viruses. These recombinant viruses, the first cases have been detected in Europe, in Denmark, France, and Germany, and Netherlands. And the first recombinant we have was a Delta Omicron Delta recombinant. This virus actually managed to have bits of their genome mixing with other variant viruses. And so these viruses emerged during the co-circulation of the Delta and Omicron virus at the very early stage of the Omicron. And then since Delta was displaced by Omicron, and since BA2 appeared in the middle of the Omicron BA1 epidemic, then we have seen some BA1, BA2 recombinant viruses, some of them having a growing factor that was better than the BA1 virus and the BA2 viruses. So we have been speculating that these viruses may be predominant, but actually it never appeared, although we have seen quite a lot of these recombinant viruses. And there's about 20 different recombinant viruses, but none of them became predominant like BA2 or BA5. Another thing that we have to keep in mind is that these SARS-CoV-2 that have been released from animal reservoir, well, they can be introduced in animals. And there are multiple examples. And one of the examples we have to keep in mind is that hamsters, golden hamsters, infected with a virus were responsible for the onset of the outbreak just because these animals were infected and they were sold in a pet shop. And these viruses actually were triggering the beginning of a new wave in Hong Kong. So we have to keep in mind, and this was observed also with human cases from mink farm, especially in Denmark. So we have to keep in mind that these viruses can circulate and be infecting animals, circulate in animals, evolve in animals, and then come back to humans and be responsible for infections like with modified virus that could be responsible for severe cases. So overall, and this will be my take-home message, SARS-CoV-2 will remain with us for a very, very long time. We have to learn to live with COVID, and these viruses will stay with us for a very long time. We have had an increasing knowledge with the surveillance system. We know about the evolution of the viruses, we know about the biology of these viruses, and since the COVID crisis is not finished, we should keep some surveillance at a very high level to be sure that we monitor properly the evolution of the virus. We have different futures ahead of us, and these futures are not exclusive. And this, we have to see that worldwide. We have to look at the issues of the recombinant virus. We have to look at how these viruses are going to evolve. Will they keep on evolving from the G-clade initial or for the Omicron variants? This is something we will have to learn. Or maybe it will come from elsewhere. So we have to be prepared for the unexpected. And amongst those for which we really need to have a close surveillance is the immunocompromised host that can be infected for months with the virus. And if this virus can adapt itself to this host and evolve, if it is reintroduced in individuals, it may have peculiar behavior. And we have to look at the retrozoonosis also, because animals are infected and they might be responsible for reintroduction of the virus within the human beings. Clearly, the immune pressure will be the driving force for the selection of the new viruses. So the new viruses that will come out, they will spread in humans because of immune escape. So that's the reason why we have to monitor this immune escape and look at the antigenic map of the viruses. Anyway, what I keep on thinking is that in the Northern Hemisphere, next autumn will be very interesting to see how this virus is going to compete with the other respiratory viruses and to see whether we will have only one season of SARS-CoV-2, or if we will have some rhythm as what has been seen in the Southern Hemisphere in South Africa, two seasons with 6 months apart. That's the future ahead of us, and we have to be prepared that maybe things are going to be much better because of the immunity that, as of today, is really well preventing against the severe disease. So I will just end up with acknowledging all the people in my labs that are working and those that have been providing information that allowed me to do this presentation. Thank you very much.
Hello, everybody. I'm Emmanuel Bernoulli. I'm working for Dassault Systèmes, and I will present you today a study that will explain how 3D simulation can help to understand both airflow and airborne pathogen propagation inside an hospital. So let's begin with the problem associated with aerosols. So of course, it is an invisible threat, and that's why it's very, very difficult to anticipate and to mitigate. And when we are talking about airborne transmission, we can already highlight different phenomena involved in pathogen propagation. The first one is how the aerosol can be emitted by a patient himself. Then on the second hand, how this aerosol will propagate and travel inside the room. And the last one will concern how this bio-aerosol can depose on surfaces and maybe contaminate people. On top of that, this behavior is very hard to analyze. As a first, let's say, thought, we can already think that it's very, very difficult to put in place experiments inside an hospital for obvious reason. And on top of that, it's even more difficult when you are in a pandemic configuration. So it's very hard to close a whole department or some rooms to really set and make and put in place these experiments within 1 or few days. And on the other hand, if you are doing experiments inside the laboratory, of course, you can master the environment and some of, let's say, boundary conditions, but you will not be able to represent all the complexity of the internal layout of the room and the impact of the ventilation of this room. So that's why in this context, the 3D simulation can really help to assess what could be the situation inside your hospital or an hospital by taking in account both architecture of the room, a detailed way of modelizing the ventilation system, and of course the patient position. And that's why we would like to show you today a study we did and published with the Hospital Bichat in Paris. And the idea was to find a way to model both aerosol movements, propagation, and deposition on surfaces, and on the other hand, try to help the healthcare workers to put in place mitigation measures that can be really, really efficient. And this study took place during the first wave of the pandemic in France, and the head of the ICU department of the Bichat Hospital wanted to have a way to understand how aerosol can be emitted by patients in his departments. And that's why he wanted to dig two different possibilities. The first one was to perform experiments in laboratory, and he initiated a collaboration with the École Polytechnique close to Paris. And on the other hand, he contacted us to see if it was possible to use 3D simulation of airflow and particles to really assess what can happen in his room. And that's why you will see in this study that we have a first part of the study that will concern, let's say, a comparison between physical tests you have on the left of the slide and 3D simulation that you have on the right of this slide. So as I said, this study has been published in scientific reports, so you will be able to find it. It's an open access, so don't hesitate to look at this paper. So first step, we need to build a virtual twin of a human in the simulation to be able to represent what can happen inside an hospital, but also what can happen in the laboratory of the École Polytechnique. And luckily, we are working on a very detailed model of a human with the top part of the respiratory system. And this is the geometry you have on the left side of the slide with a human model, including teeth, tongue, and all the respiratory system. And it was very, very key to be able to catch and predict properly all the complexity of the airflow emitted by someone, and to model both breath and cough, but in this case, it's the cough. We used the literature and basically some studies put in place by the MIT, where we will be able to catch and get all the volume flow emitted by someone coughing. And we also evaluated different particle size distribution, looking at what will happen for particles centered around 0.3 micrometers and centered around 3 micrometers. So as a first step, we wanted to compare basically the physical tests on the left of this slide and the simulation. What you are looking right here is what we call Schlieren Visualization. So it's basically a way to look at the gradients of the air density. So basically related to temperature that will be a link to the air you will emit when you will cough or breathe. And here you have the mouth of the students, you have the nose right here. We also integrated different kind of medical device, including OptiFlow, mask, without mask, breathe, talk, and so on. And we compare this kind of visualization with the same analysis in the simulation. And we basically had a look milliseconds per milliseconds, how the air will be emitted, so the air velocity emitted by someone, in this case coughing, and the jet angle of the air, and also some of the macro structures that can always be present as soon as someone will cough. Very interestingly, we saw that no matter the profile of the people coughing in this laboratory, we always had basically the same kind of behavior in terms of velocity and structures. And it was very, very, let's say, in line with the simulation prediction. So for us, it was a good way to predict step by step if the human model we have in the simulation can be accurate already at the emission of the air itself. And as soon as you are validating this, let's say, first step of emission, then you can put this 3D human model in every type of context. And in this case, we modeled the ICU room of the Bichat Hospital. So it's could be a bit simplified, but we integrate very, very important detail for both airflow and pathogen propagation. Especially, you can see in this area or this area which is the ventilation inlet, so where you are injecting air in the room. And you can see that we modeled all the winglets you have on the ceiling that will be key to propagate a fresh and clean airflow inside the room. And you have in this top right corner right here, it could be quite hard to see, but you have a small surface representing the outlet, so the extraction system of this room. Of course, since we are in an ICU department, this room was set in negative pressure by the Bichat Hospital. So that's why it's quite hard to see in the simulation model right now, but you will see that in the results in the next slide. But we are also taking into account the small gap of 8 millimeter you can have under the door that will bring the remaining air you need to put to bring inside this room, since we are in negative pressure. And in the simulation process, so we are first building digital twin of the room, introducing also the patient and the bed. Then we are simulating a first shot of simulation to understand the airflow. And as soon as we can understand the airflow, we are doing, in this case, a cough simulation. And we are looking at the cloud of aerosol, or which will behave, or which will, how fast it can be instructed, and where will be the deposition on surfaces. And then as soon as you have this very fine understanding, you can really test and take mitigation measures that are really tailored for this room. So as a first analysis, let's have a look at the airflow behavior in this room. So you are looking at airflow velocity animation. So the more red you are, the more velocity you have in this room, and the more blue you are, the less velocity you have in this room. And if we look already, what is happening as soon as you are blowing this clean and fresh air inside the room, this is the animation you have on the top right corner. It's a velocity plane just behind the ceiling and the HVAC system. You can see that because of this winglet type, you are propagating air in every direction at 360 degrees all over the room, which is pretty good if you want to clean all part of the room, because you have no dead corner on the side and the corner of the room. But you will see that it will have an impact in terms of particle control. Then, as a second step, since we are in a negative pressure, if we look at what is happening close to the door, you can see that the negative pressure effect is bringing quite high velocity air from the gap under the door, creating these jets that you can feel if you put your hands, close to the floor in this type of room. And this high velocity jet is creating a lot of turbulences, a lot of air movement inside the room because of that. And as a result, if you look at what is happening around the patient, you can see that very interestingly, you have some air that is mainly going up to the ceiling, which is a combination of all the airflow behavior you have in the room and the heat emitted by the patient himself, heating up the air close to him and creating a natural vertical flow to the ceiling. So as soon as we have this understanding of the airflow, what is happening when someone will cough? In this slide, you have on the top right corner the animation of the particle cloud as soon as someone will cough in this room. So I let the animation play a bit. For this case, we simulated a bit less than 1 minute of physical time, which is pretty good for what we want to see. And if you look at the behavior of the particles, you can see that we have different movements of the curve. The first few seconds, you have these very concentrated clouds following the jets of the air emitted by the patient when it will cough. But very quickly, this cloud will go up. It will follow mainly the airflow we saw inside the room. And then as soon as this cloud will impact or will be close to the ceiling, it will be dispatched in every direction, following the airflow we saw in the previous slide. And the red dots you have right here is related to every time a particle will be extracted by the extraction system. And you can see that even if we are in a negative pressure situation, the extraction system is not strong enough to contain most of the particles. So of course, we have a huge part of particles that are extracted in this corner, but another part of the particles will escape from this influence area of the extraction system and will recirculate in the room, going down close to the door. And then as soon as they will reach the floor area, they will be pushed away by the negative pressure jets. And then it's going inside the room again. And you are looping basically around the patient and inside the room. So a strong dispatch. And if we are looking at some statistics and some deposition map in the room, you can see that we have a strong deposition close to the, let's say, door area, but mainly on the extraction side area. And then after 45 seconds, we can extract half of the particles emitted by the patient, which is already quite good. But we have 20% of the particle that will depose on surfaces and a bit less than 30% of the particles that will remain in the air in the room. So if you are looking at these results now, how can we improve this situation? So we can already try to test some very, let's say, pragmatic and simple mitigation measure to put in place. And as soon as we have this HVAC inlet on the ceiling that will propagate air in every direction, if you want to avoid or at least mitigate this dispatch phenomena, you need to find a way to push the concentrated cloud of particles as soon as possible close to the extraction side. That's why we tested a very simple measure, which is basically changing the rotation of the bed at 45 degrees. And we are trying to align both patient mouth, HVAC system for the inlets, and extraction system over the same line. And by doing this very simple thing, you can clearly see that at the very beginning, a huge part of the cloud of particle will be quickly pushed to the top right corner of the room, where you have the extraction system. And as a result, after 45 seconds, you are extracting a bit less than 70% of the particles, which is a very strong improvement compared to the baseline situation. You are increasing a bit the deposit on surfaces, and as a result, of course, you have less particle in suspension. So this very simple and pragmatic measure can be very, very efficient as soon as you have this very fine understanding of the interaction between HVAC system and particle propagation. Then another mitigation measure I wanted to evaluate was the possibility to use a plasma in the room. So since we are in an ICU room in negative pressure, it was not obvious for the medical staff that the plasma could have, let's say, a strong impact on particle propagation and extraction. So they wanted us to test different location of this plasma and see what could be the impact of it. So we are modelizing the plasma in a quite simple way, but introducing the same amount of fresh air blown from the top face and sucked from the bottom face. The first position we evaluated, which is not the optimum for sure, you will see, is the fact that we can put the plasma just under the extraction system. And interestingly, when you look at the particle behavior, you can see that in this configuration, the plasma is not playing the role of, let's say, a pure cleaning system, but it's basically playing the role of an additional ventilation system, you know, blowing fresh air from the top face and creating a new airflow in the room that will, in this configuration, if I replay the video, will propagate most of the cloud on the opposite side of the extraction system. So basically, you are pushing away the particles from the extraction system and you are avoiding them to be extracted. And as a result, if you look at the statistics after a bit less than 1 minute, you can see that we decrease a lot the extraction performances of the whole room, going down to less than 20% compared to 69% we had before. The deposition is quite similar to what we had before. So basically, you are increasing the suspension of particles in the room if you are not, let's say, using this device in the right location. But on the other hand, if you put this plasma in a smart location inside this room, then you can completely change the paradigm. You can see that in this configuration, the plasma is still playing the role of an additional cleaning system, and it's pushing even more than what we had without it, the cloud of particles close to the extraction system on this side. If we look at the statistics after a bit less than 1 minute, we are winning a bit 5% more extraction compared to what we had before, but we are also decreasing the deposition on surfaces. And if you look at the dynamic of extraction in the long time, you can see that the addition of this plasma is speeding up the extraction slope compared to the simple thing of putting the patient at 45 degrees. So if we can talk about some conclusion about this study, it's very key to have a very fine modelization of the room and a very fine simulation software that can really predict accurately both airflow and particle propagation. We can also pinpoint the fact that we need to integrate a very accurate and detailed modelization of the room layout. We can also include some of the furniture, some of the medical devices. It's not the case in this study, but we did that for other configuration. And for sure, a detailed ventilation system, especially for the inlets, since it will give all the momentum and the direction to the airflow you will inject inside the room. On the other hand, as soon as you can have a very, let's say, accurate understanding of the airflow inside the room, you can take a very tailored mitigation measure that can be very efficient. And in this case, for example, a smart bed orientation can really play a huge role on the extraction velocity. And on the other hand, putting an additional cleaning system like the plasma in a smart position can again help you to win few % more of extraction, putting you in a very good configuration since you can increase both extraction system and also decrease the deposition on surfaces. So it was a pleasure to present you this study. If you want to contact me, you have my mail right now on the screen. Don't hesitate to write me a mail, contact me. I will be pleased to discuss with you about that. And I would like again to thank you for your attention.
So, hello, I am Professor Vincent Maréchal. I am a virologist at Sorbonne University in France. And I'd like to introduce you to OBEPINE, which is a French national sentinel network that is designed to monitor COVID-19 through wastewaters. So basically, this network was designed to answer a very important question that emerged during the outbreak in France and elsewhere. As you know, whereas SARS-CoV-2 infects the lungs, most of the patients are said asymptomatic patients because they don't have any clinical symptoms, and these patients can transmit the virus. So they are a big problem to monitor the outbreak. Recent data at the beginning of the outbreak have shown that also the virus can replicate in the gut and can be shed in the toilets, basically. So very quickly in France, an idea emerged that you could probably monitor SARS-CoV-2 virus in the population by quantifying SARS-CoV-2 genome in wastewaters and notably in wastewater treatment plants. So to answer this project, we first designed a multidisciplinary consortium gathering people coming from different fields, mainly wastewater analysis, virology, mathematics, hydrology, and some others. And these people designed a global project which first aim was to evaluate the risk of infection through the tools to sewers, wastewater treatment plants, but also in sludges that are used in France for growing plants, for example, in surface water and also in shellfish. And we have been publishing a couple of works showing that basically also the SARS-CoV-2 is present in high amount in human stools. The risk of transmission of the virus from stools, wastewaters, sludges, or shellfish to human is very, very low because the virus infectiosity fastly decreases during the life of the virus. Which is quite important as well, is that whereas infectiosity is decreasing, the stability of the viral genome is very high. And this is quite important because it means that you can follow virus RNA quite easily during the life of the virus from human stools to the wastewaters. So our first job has been to monitor French wastewater treatment plants, and mainly wastewater treatment plants around Paris, the capital of France. And this early work has been quite important because we have been able to show that, first of all, you have a lot of viral genome in wastewater treatment plants around Paris. But what is also quite important, we have been able to show that during the first lockdown in Paris, in France as well, the amount of virus that were accumulating in wastewater treatment plants was really rapidly decreasing over time, so that at the end of this first lockdown, we could not detect any significant amount of virus in wastewaters around Paris. And this has been quite important as well for the politicians in France, because it provided a very important and direct proof that lockdown has an effect of the virus circulation in the French population. So these data have been relayed in international scientific press, and notably in Science. From this early data, we have been asked by the French Ministry of Research to set up a national network based on more than 200 wastewater treatment plants. Now, for this job, we have been receiving 3.5 million euros to develop and evaluate wastewater-based epidemiology for monitoring COVID-19 outbreak. And so far, more than 40% of the French population is monitored through this Sentinel network. To set up this network, we had to follow different steps. The first one has been to choose among 20,000 wastewater treatment plants a group of 150 to 200 wastewater treatment plants. And these stations have been chosen according 40 different criteria. These criteria being economics, touristics, demographic criteria. Once these stations have been chosen, we had to develop protocols to quantify the viral genomes in wastewater treatment plants. And we also had to define a set of partner laboratories which have been in charge of quantifying viral genomes in these samples. And as a matter of fact, today, 2 samples a week are sent from each wastewater treatment plants to the partner laboratories where analyses are performed. So once we got this data, obviously we got raw data, I mean just viral RNA concentration in wastewaters. And these data, as you can imagine, are very dispersed. You may have aberrant data, you may have data under the level of detection. So basically, it's a matter of biology. As you know, there is a huge variability when you get biological data, and you can see this on this simulated set of measurements. So we ask our mathematicians to work with us to design a mathematical model to get a more precise curve that would be interesting to work for the rest of the project. And what we have been able to do with our colleagues is to use both raw data, I mean concentration of viral genomes in wastewaters, but also additional information such as the water flow in wastewater treatment plants, such as the rainfall events that may have occurred, but also we use physical chemical data that would characterize wastewaters, and all these data were gathered and used in a mathematical smoother to provide the curve, which is the red one on the graph. And as you can see, this red curve, it's very close to the true data that are expected from this kind of simulation. So basically, we got the whole pathway to get the samples, to analyze them, to make modelization. And once we got all this data, we design a website where each week we will produce a report, a local report, over 200 wastewater treatment plants. And this report was both sent to the French health authorities, but also to the citizen. So what can we find in this report? You can find a sort of weather report indicating the level of circulation of the virus over the different stations. And you can also find the trend of this circulation over the 7 days or last 30 days, which is an example you get on the slides. We also provide in each report the incidence of the virus in the wastewater treatment plants. And as you can see here on Paris eras, you can nicely show the first wave, the second, third, fourth, fifth, sixth, and maybe seven waves of virus in the wastewaters. And on each report, we also add the classical epidemiological data, I mean the incidence rate, but also the hospitalization admission for COVID-19. When we get all this data, we try to make science, basically. And the first question was, would the wastewater indicator be better or worse than other classical epidemiological indicators? And as you can see on these slides, on these 10 towns we choose for the purpose, you can see that the level of circulation of the virus in wastewaters in red is very close to the incidence rate that you can have on these slides on black. So this is the first result. It means that if you don't have individual massive testing, you can still have a nice idea about what happens on a local era just by monitoring the corresponding wastewater treatment plants. So once you get that, you want to know whether the wastewater indicator is a more early or more earlier indicator than the incidence rate. And as you can see on these two examples, we have been to show in wastewaters that the signal when the virus amount increase or decrease, these signals occurs earlier than the signal you get if you have a look on incidence rates. And this is very important because you can say the health authorities that something happens, a good or a bad thing, depending on the case. Okay, last question was, is it possible to monitor SARS-CoV-2 variants to wastewater-based epidemiology? As you know, SARS-CoV-2 variants have many important properties, such as viral escape, modulation of virulence, or eventually the possibility to go through different animal species. So it's quite important to monitor this variant and to have an early signaling system to say that the variant is growing on a dedicated territory. And as each variant is characterized by a set of dedicated mutation, we have been able to design specific RT-PCR to detect variants and eventually to quantify variants in wastewaters. And this is illustrated by the following slide. These are the data that have been collected in Paris era from November 2021 to March 2022, showing that you can evaluate the amount of different variants. I mean here, the Delta variant in blue, the Omicron BA.1 in orange, or the Omicron BA.2 in green. And you can see that these variants are coming next after the other. So it is quite interesting strategy to monitor the variants, but we are now developing metagenomic strategies to be able to detect known variants, but also to detect variants that may emerge and are not still detected in the human population. So it's a kind of early survey of what may happen in the human population just by monitoring wastewaters. Okay, so the conclusion of this approach is that actually wastewater epidemiology is not brand new. It's an old approach that has been used in the past, for example, for the polio virus. But wastewaters monitoring has not been used at such a scale in France, but also in other countries in the world, in the Netherlands, for example, in the US, in Germany, Spain, Italy. Wastewater incidence reflects and often anticipates the incidence rate in the human population. So it's very interesting to get an early signal for the dynamics of the epidemics. I'd like to say also that the benefits over cost ratio is just exceptional. For example, in January 2022, 40% of the French population was followed using 300,000 euros. And to get the same epidemiology curve, 46 million testing have been done in France for a total cost of 1.6 billion euros. So obviously, individual testing has also a very important use in terms of isolation of the patient, detection of positive, and limiting the transmission of the virus. But as an epidemiologic tools, I would say that wastewaters is much more interesting. And however, it should be underlined that both strategies are very complementary and should be used depending on the question you want to answer. Wastewater analysis is probably very useful when individual testing rate is low, which is currently the case in many occidental countries where we consider that the epidemics may be more severe than it has been in the past. But wastewater epidemiology is especially useful also in low-income countries or when individual testing is not possible. So we are actually working with other countries in the world to set up wastewater-based epidemiology in the case of SARS-CoV-2, but also as a tool to monitor other pathogens. And we are working currently on respiratory viruses, such as flu or other coronaviruses, but we also try to use this kind of techniques for the early detection of emerging disease, and this is currently the case for pox viruses in wastewaters. Okay, I'd like to point that the project was a really collaborative project conducted by many colleagues on the slides, people at Haute-Paris, Laurent Moulin and Sébastien Wurzer, colleagues at the University of Lorraine and CNRS, Isabelle Bertrand and Christophe Gonzer, some other colleagues at Sorbonne University, including Yvon Madet, Jean-Marie Mouchel and myself, Michael Bonny at Institut de Recherche Biomédicale des Armées, and finally Soisic Le Guyadère at IFREMER. Thank you for your attention, and I'm ready to ask any question if you have any.
So, is everybody here?
Yes, we are.
Okay. I don't see yet the other panelists, but if you hear me, we have many questions. Can we start? Okay. So first of all, thank you to all the speakers who gave wonderful talks and raised many questions as usual. Among the questions we have one from Zaid Hussein, so I'm saying hello, but in fact, Bruno Lina has beautifully answered the question. The question was, why in spite of 2 vaccinations and a booster, would somebody get infected again? I think we covered this with you, Bruno Lina, and thank you very much. We have a question from Rafael de la Camara, who is our chair of the Infectious Disease Working Party of the EBMT. And I think this question would go both to Bruno Lina and Vincent also, Vincent Maréchal, for the following reason. The question is, can variant surveillance predict the next virus, the next pandemics? And partly, Bruno, you did answer, and also Vincent. So which one of you is starting?
Bruno.
Bruno.
First.
Okay, go ahead.
Yeah, thank you for the question. Actually, it's very difficult to predict things at the very early stage during the emergence of the viruses. What is important is to understand what are the new features of the variant when it emerges. You know, there's been so many different lineages that have been identified. And if you look at, for example, the BA2 lineages, there's about 40 different lineages within BA2. And there's one which is supposed to be more transmissible than the others, which is BA2.12.1. So what we need to do is to look at the differences in the structure of the protein spike, to look at potentially escape mutant to the immunity. It's really the immunity that drives the evolution of the virus and the selection of the new variants. And then when there's a new virus coming, we have seen the row of BA1, then 2, then 3, then 4, then 5. As you may have noticed, as BA3 has been responsible for nothing, whereas BA4 and 5 seems to be responsible for the new start of a wave in at least Europe and Africa. But we don't know the size of the waves because of the pre-existing immunity. So monitoring of the variants through sequencing is interesting. It will identify different new viruses, but it may not be able at the very early stage to predict about the evolutionary pathway of the virus and to see whether these viruses, the new ones, are going to be responsible for waves or not. We need some time, and you need to be able to look at the rate of transmissibility and the rate of escape to previous immunity to try to predict what will happen.
Vincent Maréchal,
yes.
you have an additional answer?
Thank you for this question. So now it's quite interesting. What can help wastewater to do is probably to detect, not as an exhaustive manner, but at least as a quite comprehensive manner. You may expect to detect by metagenomic approaches virus genomes that are not still detected in the human population. And this kind of approach has been successfully used in New York a few months ago, where people have been finding in wastewaters viral genomes that are not detected in human population. So it will not predict what will be the future dominant variant, but it may help you to detect new variants in a quite early manner.
Okay, thank you. And then we have a very long question from Rolando Quijano from the Agence de Biomédecine here in France. And just to summarize the question, it's about bone marrow or peripheral blood stem cell transplants. Part one of the question would be, is there any report of a proven transmission of the SARS-CoV-2 infection, COVID, from a donor to a recipient of stem cell transplantation? Any one of you would have an idea about this? Probably I should, but I'm not aware.
I don't know.
Because the second,
we know, but I have no idea.
I am not aware. It doesn't mean that I'm sure that it never happened, but I'm not aware about such a report.
On the other hand, I would complete this question by saying, are you aware of a transmission by, let's say, transfusion in some countries? I mean, can it be transmitted by blood?
Well, supposedly it could be transmitted because we know that this virus is in the blood of the infected individuals, at least those that were naive, and those that were having severe presentations. In the early stage, we showed that there were a significant number of viruses that could be detected in the blood of the individuals that are infected. Whether this has been responsible for transmission, this I don't know. What I have seen some reports from transplant patients that have been infected through an infected graft. But in all cases, it went well. There was no severe cases, and it's very limited number of cases. So it never really happened a lot. And when it happened, there was no consequences on that. We have, however, to be careful with the immunocompromised because they might not be able to control the virus after an infection through transplantation or through any graft. So let's be careful. But so far, there was almost no cases, very limited number of cases, and mild ones, to my knowledge.
Okay, and there is a third part of the question by Rolando, which is, would you in a particular case accept to take a donor who was tested positive, but the question is when, how many days before, and so on, to transplant a patient? I myself, as a transplanter, I would delay the transplant. I think it's not so difficult in general to delay a transplant by 7 days or even 14 days. And if you cannot delay the transplant, usually it's a really poor prognostic transplant. So this would be my answer as a transplanter, and maybe Bruno or Vincent, you want to give an additional answer to this?
No.
Okay.
I think it's probably a good answer. I don't know what Bruno thinks about that, but you may think it's more prudent to wait until the variant is low.
Yes.
Yeah, it's always a question of how much is the what is the risk and the benefit. So if because of if there's a need, an urgent need for a graft, I would certainly not postpone and put at risk somebody that would be really on a matter of days, with the risk of dying because of an organ failure that would require transplantation. Otherwise, what you propose to postpone a little is really wiser. So that's the balance between the risk and the benefit.
Postponing is what we did during the COVID pandemics, wave 1, wave 2. So it makes sense, at least to me. Then I have a question for Emmanuel Bernoulli. In fact, after your presentation, do you conclude that you would offer to reshape all the rooms in the ICU in general? Because it's not only this virus, it's true for other viruses, maybe also bacteria, I don't know. So are you saying that the rooms in the ICU should be reshaped?
That's a very good question. In fact, we did some work with other hospitals on how can we rehabilitate some ICU departments, and the idea was to play with the position of the extraction system and the blowing system. And it seems that we do not have the perfect answer for every type of room, but it's highly depending of the internal architecture and the layout of the room. And on top of that, the position of the patient is very key, to have a very good, let's say, extraction performances. What we saw yet is the fact that if you put in a smart way the extraction system quite close from the patient, you are able to catch as soon as the aerosol will be emitted by the patient. So before the cloud will explode and dispatch all over the room, but you will be able to catch a huge part of it. So then the remaining aerosol in the room will be much lower than what you can have with a classical, ventilation system on top of the patient. And then the idea will be to play with both location and shape of the ventilation system to create a kind of smart airflow that will always, propagate the air and the aerosol close to the extraction system. So that's basically, the way we are working on rehabilitation of rooms. So I do not have the perfect answer for all the rooms, but it's always tailored. But we have some space to improve, definitely, the performances for ICU, but even all the classical rooms we have in hospital, for sure.
Thank you. So we have still a few minutes. I have a question for Vincent Maréchal, and then I have my own question for Bruno Lina, and then we will see. For Vincent Maréchal, workers in sewers of Paris. I remember when I was younger, if they were bitten by rats, of course, they were going immediately to the hospital because of the risk of leptospirosis, and they were to receive antibiotics and so on. What would you say today if somebody working in the sewers come to you and say, I got COVID in the sewers?
I think that it's very difficult to provide evidences that contamination occur in the sewers. So we had this discussion with people in Paris because at the beginning of the crisis, they wanted to know whether the people working in sewers were at risk, high risk of contracting the virus. And so people working in sewers are very well protected, as a matter of fact. So they are not at high risk of getting the virus. And most of all, as we've seen, the virus is quickly degraded in stools and is more degraded in wastewaters. So the risk assessment has been done such we cannot make sure that there is no risk, but we can say that the risk is very low compare with being in close contact with somebody having the COVID-19. So the risk is minimal compared to other opportunities to get the virus. I would say there is no major risk for COVID-19 in sewers.
Okay, thank you. I have another question before mine. Oh yes, this is the story about the hamsters. Bruno, at the end of your talk, you mentioned the hamsters for Hong Kong. What about kennels for dogs, cats? Anything reported on this?
Yeah, there are some reports, not with camels. Camels is only MERS coronavirus. It's not SARS-CoV-2.
No, I was saying kennels. I'm sorry, it's kennels, meaning the place where you gather all dogs
Oh,
together.
okay. Wait, sorry, I didn't understand that. So, yeah, I mean, all the animals close to human beings infected can be infected. And there's a recent report about a cat that infected somebody in a household. So, and there has been report about infection in dogs, cats. There are deers that are infected in the US, and there's all sorts of rodents could be infected by this virus. So, and there has been multiple reports from different animals that have been infected. This virus is really transmissible to a very large variety of animals close to the human beings. So, the big question is whether there could be a sustained transmission in kennels, like you said, and then a virus that would go back to humans with some change. Again, this has not been reported yet. The only reverse infection that was really well documented was those from minks in Denmark and the Netherlands, and with these golden hamsters in Hong Kong. Otherwise, there was only sporadic cases. So, but we have to be careful because that might be possible.
Okay, now I would like to ask the last questions because I was told we have 1 minute to go, but maybe it will be 3 minutes. The story is the following. You are telling us, Bruno in particular, but also Vincent, that we are going to have to live with this virus for maybe years or decades. And you are telling us that we will have to get a booster or whatever you call this every year. But I would challenge you, and I would say maybe every 6 months. And I would further challenge you because we now have here and there some reports of non-severe, but still unpleasant adverse events when you do number 4 injection. And I'm not speaking of immunocompromised patients, I'm speaking of normal people. So the question, if you consider one person, it's bad, it's very bad. But if you consider one person and you say, well, why don't you dose your antibodies? And I'm trying to find a threshold above which you would feel protected. And I looked at your slides, and what I see is roughly that if you have 1,000, is that BAU? I don't know. If you have 1,000 or above, you should be, I would say, reassured in a way, but I'm not sure. What do you think? And the other thing is, what about the next vaccine? Everybody is waiting for this. And what would it be?
These are, well, it's not a difficult question, but it's difficult to have a straight answer on that. So regarding protection, I don't know if Vincent would like to build on that afterwards, but there's no correlate of protection as of today. We can't be sure, based on the serology, that we can predict that somebody will not be infected. That is not possible. The likelihood of being infected is reduced when you have a serology with a BA above 1,000, like you said, and the likelihood is really low, but you cannot say to somebody based on a serology that he will not be infected and that he is completely protected. That's what we see with other viruses and with other respiratory viruses. We know that serology cannot predict about the risk of being infected or not. However, when you have very low antibody titers, and when you're exposed in the context of a circulation of viruses that has increased, then the risk for you to be infected is high. And we know that based on the cross immunity you may get through infection plus vaccination, if you are close to a recent event, either immunization through vaccination or to exposition to a virus and mild infection, then you can be protected for between 4 and 6 months. And this is pretty robust. Okay, but this is based on the fact that there's no evolution on the virus. And so let's go back to your second question, which is the new strains that could be used in the vaccine. We are waiting for that because we know that the breadth of protection you get in terms of antibody is really increased when you change the antigen that is used for vaccination. And this is basic science we know about beta coronavirus, and especially what we have seen in the animals with the vaccination. So this change in the antibody composition, in the antigenic composition of the vaccine is important, but this has to be done in a meaningful way. I mean, we have to change because it is important to change. And as we have seen so far, until the emergence of the Omicron, there was no very good reason to change the component of the vaccine because those viruses were very, very similar. Now we do see some differences, so the change in the vaccine composition makes sense. It is probably vaccine that will become to be available in October, but we will not be able to vaccinate everybody with that vaccine in October, because the release of the vaccine will be on a long scale, and so we will have the first 1,100, and then the first million, and then the first 10 million, et cetera. So it's always a question of balance between risk and benefit. Having a vaccine shot is never something that is trivial. Having an infection is not trivial either. The question is whether there's a risk of being infected or not. So it depends about the epidemic, but a vaccine is efficacious only 7 days after administration. So that's the policy now in France is to push the at-risk patient to have a second booster dose because there's an increase in the BA5 cases. But it is difficult to say that everybody should be vaccinated. I wouldn't say that. So that's, that's what I can say. I don't know if Vincent can say more.
Well, I just would like to add that probably the situation will be very different depending on the countries. France definitely made the choice, which is to make a mixture between efficient vaccination and now vaccination of the more at-risk patients. But we also decided to let the virus go. As you have seen on the recent data in France, the virus is really circulating, but it's not a big deal. If the more sensitive patients are protected by vaccination. It may be quite different if you have a look on China, for example, where the vaccine policy has been quite different and they are kind of trapped in these zero COVID strategies, and they cannot release these zero strategies until they have a very efficient vaccination policy. So the answer may be very different from one country from the other. And the other thing is that you don't know how the virus will evolve in the next future. We have been used not to make any prediction 6 months ahead about COVID-19. So I would be very prudent on what we need to do in 6 months or 1 year.
Yes, but Vincent, we count on you because you are checking waters. Okay,
thank you.
We ring the bell. Okay, so it's the end of this webinar. Again, I'm very grateful to you. I thank the audience. I thank Air in Space, and I hope it will remain in the archives. Thank you very much.
Thank you.
Thank you.
Bye-bye.
Thank you.
Yeah. Goodbye.
Goodbye.